Okay, welcome everyone. Welcome. We'll just wait a minute and give people the opportunity to log in. And while we're doing that, I'm just going to go ahead and share my screen. So just bear with me. Who can share? Share screen. Here we go. Welcome everyone. Nope, this is not what you need to see. Let me just get the technology working here. Here we go. Oh, hi, Shanti. We have you as a panelist. I'm going to move you to a attendee.
Okay, thanks.
Bye. Okay, let's try to share my screen again. I'm having Zoom brain, which means everything is 10 times harder than it actually needs to be today. Here we go. Share, and I'm just going to make this big. Here we go. Bring your shared window to the front. What does that mean? Can you see my screen? Can you see the full screen?
Yeah, we can. It's not in presenter format. It's just I can see the slides.
Okay, I'm going to try this again. Get it up and running correctly in the back end, and then I'll share it. Okay. How about now?
Yeah, I can just see your desktop as well, Erin.
You can see my desktop.
Yeah, so maybe if you just maximize that screen, I think.
Okay, let me try again. Hold on a second. Sorry, everyone, for the technical difficulty here. I usually have this all working fine right off the bat, but make yourself comfortable. Feel free to pop an intro. Oh, hi, Selena. Make sure to pop an intro in the chat window if you want to say hello. Okay, let's try this again. So if I make it insert, slideshow, setup slideshow, browse by an individual screen, play from start. Okay, let's try this one more time. How's it looking?
Looks great.
Can you see my whole desktop?
No.
Oh, really?
No, looks good.
Okay, we got there. Welcome, everybody. Thank you all so much for coming along this evening. We'll go ahead and get started. Okay, I'll stop moving it around. We'll go ahead and get started. We're really excited tonight to have the opportunity to talk a little bit more about the evidence base for early intervention for autism. And part of this is part of our NDIS webinar series for parents is really helping empower parents to understand what intervention supports have established evidence behind them, because we know the intervention market for autism is booming, and we know that there's a lot of things out there on the big wide world of Google that lack evidence about their effectiveness for supporting young children and families. And so we really want to use this opportunity to try to separate fact from fiction, talk a little bit about what sort of holistic early intervention programs look like and how they align to government recommendations for best practice early intervention, and talk a little bit about interventions that you might hear about which actually lack any scientific evidence or which may in fact be harmful. But before we do that, we just want to acknowledge the traditional custodians of the land in which we meet tonight. The Autism Behavioral Intervention Association acknowledges the traditional custodians of country throughout Australia and their connections to land, sea, and community. We pay our respects to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. We also just want to highlight a few upcoming events at ABIA. There's a lot happening right now, and we make these events as accessible to families and parents as possible. So we have our upcoming ABA Today conference on. Tickets are currently on sale. This event will be held in October of 2021, the 14th and the 15th. Or is it the 15th and the 16th, oh gosh, of October. You can visit abiatoday.com.au to learn more. The theme of our conference this year is Voices and Choices, and we're using it as an opportunity to really highlight the voices of autistic people and their families who have lived experience with evidence-based, ABA-based programs, and also how the provision of high quality educational and behavior supports can really provide more opportunities for choices for people on the autism spectrum throughout their life. Oh, it's the 15th and 16th. There we go. It will be a live streamed virtual event. Tickets are on sale now at our crack and egg prices, so be sure to check that out. We also have some upcoming ABA therapist trainings, which you can find out more on our website. And finally, we have our fourth webinar in the Navigating the NDIS series for parents that will be held on Monday, the 12th of July. And in that session, we'll be talking about choosing the right therapy provider. So once you get your plan, how do you go about looking at different providers and choosing a therapy provider that's going to best sort of match to your family's needs and your child's needs? Okay, so we have a couple of objectives that we want to address in our presentation tonight. The first is that we want to describe models of therapy for children with autism and really emphasize and distinguish between therapies that have an established evidence base from those without evidence. We want to talk about what we call the essential practice components of evidence-based early interventions for autism. So it's really important to note that there is no one-size-fits-all therapy for children on the autism spectrum. Therapy is a very individualized, very dynamic, and can actually look a lot of different ways depending on the strengths and needs of your child. And so we're going to highlight what some of those essential practice components are and how a provider might go about individualizing a therapy program for your child. And then finally, we're going to talk about some important considerations and red flags when selecting a therapy. So as I mentioned at the beginning of the presentation, unfortunately, the autism sort of intervention market is booming. There are over 500, yes, we've counted them, over 500 distinct marketed interventions for autism. And sadly, the vast majority lack any scientific support regarding their effectiveness. And some of them have actually been shown to be harmful. And so we're going to talk a little bit about what to look out for. And when you are kind of evaluating the claims around a specific therapy, what types of questions to ask to ensure that you're selecting a good option that's most likely to be effective for your family and for your child. So as we go, feel free to pop any questions that you have in the chat window or anonymously through the Q&A. We'll have some time at the end to take questions, and I'll be facilitating that at the end of the presentation. So go ahead and just anything at all, type it right into the chat window or the anonymous Q&A. But I do want to introduce us, your presenters for this evening. Many of you may know me. My name is Dr. Erin Leaf. I am a senior lecturer and educational researcher at Monash University. I work in the Faculty of Education in the Inclusive Education Education and Educational Psychology group. I'm also the vice president of ABIA. And I'm really, really passionate about making research findings more accessible to parents and clinicians and people who maybe aren't coming into research as part of their day-to-day work. My own current research at Monash really is centered on the evaluation of strategies for building the capacity of the workforce to select, adapt, and use a variety of evidence-based practices to better support people with disability. In particular, my research focuses a lot on individuals with quite significant support needs who may be most at risk for behaviors of concern or exclusion or social isolation. Next, I'd like to introduce Shannon Eels. Shannon, give a wave. Shannon is the Managing Director of Autism Partnership Australia, and in this role, she leads a team of passionate and talented clinicians to achieve the best possible outcomes for children with ASD and their families. And Shannon now plays a key role in working with families to help them navigate the NDIS and secure funding for early intensive intervention. And finally, we have Bob Buckley. Hi, Bob. Bob is a parent, advocate, and convener of Autism Asperger's Advocacy Australia, also known as A4. A4 was formed in response to growing demands from people with autism and their families who wanted more direct involvement in raising the profile of autism-related issues with decision makers, government, and through the media. A4's advocacy gives a voice at the national level for individuals and groups involved in autism and ASD across Australia. While helping individuals navigate the NDIS specifically is not part of Bob's systemic advocacy work, he has helped many families navigate the NDIS, and in particular, the review and appeals process. So all of us have different experiences navigating the NDIS or helping families learn to navigate the NDIS. All right. So the first thing we need to talk about is why this topic is important. Why is it important to be able to understand the evidence base for different therapies and supports for children with autism? Well, the number of children diagnosed with autism has increased. There's a number of reasons why that may be the case, one of which is that the diagnostic criteria has become more inclusive, and we're in fact correctly diagnosing more children with autism now than we have in the past. And research tells us that autistic people may face a higher likelihood of exclusion, for example, exclusion from mainstream schools or from community-based activities. They may be more socially isolated as a result of exclusion, or they might face difficulties in school and employment later in life. Autistic people may face fewer opportunities. They may have fewer opportunities to make choices about what they want to do in life, and more restrictions than their non-autistic peers. And this is particularly the case for autistic people who maybe display behaviors of concern, are not able to communicate as effectively as their peers. But we also know that autistic people can gain skills. They're capable of learning a whole heck of a lot and experience meaningful participation and social inclusion. With the right support, autistic people can live a life free of restrictions and experience true meaningful inclusion. And that's ultimately the goal of therapy, is to help the person gain the skills that they will need to be able to participate in all of the good things in life that they want to do. And we think that parents need to be informed. And the reason why is because parents are the number one advocate for their own child. Parents need to be informed to ensure that their child receives safe, effective, and individualized educational and behavioral support. And again, this is important because there are over 500 different marketed interventions out there on Google. And so making sense of the autism intervention market can be really, really confusing. We also want parents to know that children with autism are capable. They're capable of learning a lot. And we don't want parents to fall victim to what I call the tyranny of low expectations, or the idea that parents just need to accept that their child is going to need specialized support for their whole life. And even if they do require specialized support into adulthood, they can still learn a whole heck of a lot and experience all that life has to offer. One of my favorite quotes about supporting kids with autism is that if the children do not learn the way we teach, then we change the way we teach to better suit the way they learn. So really individualizing the program to meet the child where they're at and to suit the needs of the child is so fundamental. And that our goal isn't to force the child to learn in a way that's convenient for us, but it's really about understanding how the child learns and continually searching for the best way to teach them that is a good match for how they learn. And so really, when we're looking at evidence-based interventions and supports for children with autism, it's really up to us to change how we support the child to meet the child's needs, rather than fitting the child into a one-size-fits-all approach. So I would say, if a therapy is delivered in the same way, in the same stages to all of the children, that I would be skeptical of that type of approach. So the NDIS has proposed some core principles that are important in any early autism intervention. And I didn't make these up, these are on their website, but I agree with them. So the core principles that are important to interventions for children on the autism spectrum are, first, the use of a holistic assessment. And this should be an objective assessment that incorporates a lot of different assessment methods. And the purpose of the assessment is to identify the child's strengths, their challenges, their goals, and their preferences. And using this initial assessment intervention information to establish a set of maybe short, medium, and longer term goals, and then to create an individualized program that's going to help the child make progress towards meeting those functional and important goals. The second is that the program needs to be individual and family centered. So the autistic child and their family are equal partners with the clinical practitioners in the delivery of services. And I always say that who decides the goals? You, the family. The clinician will help you. They might help you better understand sort of developmental stages and the types of skills and what order we might teach them to sort of promote optimal learning. But ultimately, the goals are yours. And a therapy provider should be able to work with you to individualize the program to work towards the goals that you find important. Therapy should also take a lifespan perspective, understanding that as the child learns new skills and gets older, the types of supports that are made available and the way that those supports are delivered and the goals that the program might work towards are likely to change. And children will move from early childhood settings into school and ultimately into adult life. And so a program needs to be adaptable. With that being said, I don't think that you should be seeking programs that are sort of saying, well, we're going to get you in an early intervention. We're just going to keep you as our client until you're 65 years old. We ultimately want to try to take a step down model of support as the child gets older and no longer needs the level of support or intensity of support that they may receive in early childhood as part of an intensive early intervention program. And finally, the intervention, the strategies should be evidence-based. So what this means is that we're able to look at what the research literature says is effective when it has been evaluated using a variety of different research methods. So in other words, research tells us with more confidence that it's a intervention or a specific support strategy that was responsible for improvement and not some uncontrolled variable. But it's not just taking what we've learned off the pages of peer-reviewed journals and applying them to humans in real life. We also need to be able to look at the goals and values and needs of all of the individuals that we work with and ensure that the programs are individualized to suit the needs of the child. And that might involve changing how the program looks from how it was described in research, but still staying true to those underpinning sort of component parts. And the way we do that is by using clinical judgment. So really what we mean here is that it's this triangle integrating information about what research has shown to be effective with the goals, needs, values, preferences of the individual and their family using clinical judgment. That's the process of evidence-based practice. So good practice should include a couple of different components. First is that the supports for children should be evidence-based and delivered using a family-centered approach that incorporates individual planning. The specific early intervention program will take into account family preferences and capacity, and each child's strengths and difficulties, age, and stages of development. So again, it's about matching the program to the specific and unique needs of each individual child, really highlighting the importance of individualization. And the way we come to know about the child's strengths and difficulties is through the use of that holistic assessment at the beginning of the intervention journey. The aims of support for the child with autism ultimately look at improving social communication, improving the child's ability to communicate their wants and needs in ways that are safe and understandable to other people, improving their ability or helping them to form meaningful relationships with other people, minimizing behaviors that challenge. So we know that challenging behavior doesn't just go away as kids get older. In fact, it just gets more difficult to manage. And so early on, we want to take a really proactive and preventative approach to addressing challenging behavior. But a good program will ultimately understand that challenging behavior is communication. It serves a purpose for the child. And the very best way that we can help kids with their challenging behavior is through the teaching of new life skills, in particular, the teaching of new ways of communication. Early intervention should start early. That's one of the critical components. Ideally, as soon as the diagnosis is made, if not earlier, when the family maybe detects red flags or has some concerns about their child's development. But of course, the family needs to be ready and they need to be able to explore their options. And finally, good practice should have a team approach. So we're looking to build a team of well-trained professionals around the family and the child to provide that support. Parent training and parent coaching is really important. As is including siblings or other family members within therapy. Bob will talk about this a little bit later on. It is important that when we're talking about the inclusion of parents, and family members that we are distinguishing between parenting and therapy, because those things are different. And parenting does not mean the same thing as delivering evidence-based therapy, but there are still a lot of different ways for parents to be involved in every step of the process. So far we've talked a little bit more about sort of the underpinning principles, or what you should be on the lookout for when you're looking for a therapy program. Within a therapy program, there are a number of different practices or strategies. You might call them interventions, you might call them strategies, you might call them teaching methods that have an established evidence base. So these are methods that have been shown to be effective for teaching a whole range of new skills to children with autism. Some of them are listed here. One of the key skills that we often work on in an early intervention program is building the child's imitation capability. And it seems sometimes like, well, why are you just getting them to imitate you when you clap your hands? Like, that doesn't seem very functional or contextually appropriate. And you're right. What we're trying to do is establish what we call a generalized imitation repertoire, where the child is actually able to look around them in the natural environment and learn by watching others. That's a way that typically developing children learn a whole host of new skills just through their day-to-day interactions in the real world. So establishing that imitative repertoire is a really critical component of early intervention. We consider that a learning to learn type of skill. Using visual supports. So sometimes listening to the words spoken by others is difficult. The auditory information is so fleeting. You say it and then it's gone. But supplementing that with visual supports can be really effective. So in some cases, we may use structured teaching, which can also be called discrete trial teaching, which involves breaking down a task into its smallest teachable components. And the reason that we do this is because it allows the instructor, the teacher, to provide a really clear and consistent instruction to the child. It allows the teacher to provide help, or what we call a prompt, on every single trial to maximize the child's success. It allows us to provide a high rate of positive reinforcement for successful participation, cooperation, demonstrating the new skill. So when done well, discrete trial teaching is really fun and rewarding for kids to participate in. And we're able to get in a high level of teachable opportunities within a small amount of time. Practice, 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 but in a really fun and engaging way. By contrast, we use more naturalistic teaching strategies as well, which is finding teachable moments within the context of play and daily routines. This is different from just day-to-day interactions in that we look to create lots of teachable moments. And again, within those naturalistic teachable moments, we are able to provide prompts, there's some help, and then we're able to richly reinforce the new skills that the child is demonstrating. Positive reinforcement is a big one. Positive reinforcement is not the same thing as rewards. This isn't just about giving kids a lolly every time they do the right thing. Positive reinforcement is a highly individualized process for every child. And part of our job is to identify what is reinforcing for your child. And also introducing the child to natural reinforcers, social reinforcers, the types of natural consequences, positive consequences that kids come into contact with every day, and establishing those types of things as reinforcers for children with autism. Functional communication training, which involves teaching your child ways to communicate their wants and needs that's safe and understandable. We know challenging behavior often serves a communicative purpose. So we really want to look at replacing challenging behavior with other ways of communicating, while understanding that not all communication is vocal speech. So often it's about looking to individualize the communication method for your child, whether it's gestures or pictures. We have the picture exchange communication system here, giving them an alternative method of speaking if speech is not an effective or efficient way for them to communicate. Everything we do, we prompt. We proactively set the child up for success so we can reinforce and celebrate their successes, and then gradually fade out our prompting as the child becomes more independent, because independence is the goal. And task analysis, which involves taking a chain of behaviors like washing your hands and breaking it down into its individual component steps, and then systematically teaching each step in the chain. So we might use something like this to teach things like washing your hands, getting dressed, making a snack. Now, what's important to know is I've just listed and described a number of different strategies or teaching approaches. These can be delivered individually as part of a focused program. So what I mean by that is that the child might receive some targeted support in one area, such as learning emotional regulation skills. And we might use one teaching tactic as part of that focused program. But for a lot of young children with autism, we're delivering a combined or a comprehensive intervention, which is designed to address skill deficits and needs across a variety of developmental domains. So we might be looking at communication, expressive language, receptive language, play skills, and we would use a combination of different teaching strategies within that program. So that's how we're differentiating the practices that have an evidence base from the overarching principles or the components, how we might put a program together. Now, there are a number of interventions that don't have an evidence base. These are just some of the ones that were highlighted in a 2016 report written by Pryor and Jackie Roberts and Katrina Williams, that was written for the NDIS to provide some more information about, what types of interventions should be funded through the scheme. So what the authors noted is that the therapies listed here don't have evidence to support them. Now, they don't have evidence, I would say, no, that's not true. Some of them now have evidence that actively does not support them. It actually shows that it doesn't work and that it can be harmful. We'll look at those in a minute. But this is just a subset. If, as I'm talking about any of these, or you see something that's a bit weird and you want to know more, just go ahead and pop it in the chat window and I'll try to circle back and tell you a little bit more about this type of intervention. But these are interventions that don't have an evidence base and really maybe shouldn't be funded. And then there are some interventions which have been identified as being actually harmful. So research has actually shown that pursuing some of these types of interventions can have harmful side effects. And when you're looking at these types of interventions, it's important to note the problem that these interventions are proposed to address. So, for example, chelation is actually a medical procedure for people who are experiencing mercury poisoning. That is a medical condition. Under that condition, chelation may be the appropriate treatment as prescribed by a doctor. Chelation as a treatment for autism can be harmful. It can have side effects, including death. This has been documented. So it's really important to note that interventions that maybe have a purpose for specific conditions are now being applied as a treatment for autism in the absence of evidence to support that it's effective. Another example is exclusion diets. Of course, if a child has a food allergy or an identified gastrointestinal issue, a doctor may prescribe to exclude certain foods from that child's diet. And of course, all children should have a relatively healthy diet with a variety of foods. But when we start to exclude entire food groups from a child's diet as a way to try to address their autism, the child may actually not get the nutrients that they need to thrive. And in my career, I've actually seen children who have been diagnosed with psychosocial dwarfism because their diets have been so restricted that they failed to grow. There are real serious side effects if these things are implemented in a really inconsistent way. Same thing for medications. Of course, some people who maybe have seizure disorders, anxiety, other neurobiological mental health conditions like schizophrenia may need to be prescribed medication. But at present, there is no medication that has been shown to be effective for treating the core symptoms of autism. So it's really important to be informed about the different types of interventions that you'll hear about. And a website that I really like is the Raising Children's Network, which is actually an Australian government website. And I've provided a link in the end of the slideshow. But if you go into Raising Children Network, you look up Autism Parents Guide to Therapies, they will provide a definition and a rationale for all of these different interventions and rate the level of evidence. And you'll be able to learn more about a whole lot of interventions that you might have heard of to learn whether or not there's sort of evidence behind it. The other thing I want to stress is that restrictive practices are not therapeutic interventions. Restraint, mechanical restraint, seclusion, physical restraint, they are not therapeutic interventions. They may be used as a last resort in some cases when behavior is extremely risky and puts the person or others at a significant risk of harm, but they should never be used as a sole intervention component, and they are only used in crisis to manage safety. They should not be used as your first action when helping people who experience behaviors of concern. So this is the last slide I'm going to talk about, and then I'll turn it over to Bob. There's some questions around whether child characteristics influence intervention outcomes. In other words, can we say, oh, my child is this age, they're this level on the spectrum, they present with these types of needs. Can we say for sure which intervention is going to be most effective? No. But the beauty of early intensive behavioral interventions and ABA-based interventions is that they're so highly individualized to the child that we can accommodate for individual differences. In fact, individual differences is the heart and soul of the types of ways that we practice. However, there's a little bit of evidence to suggest that kids with higher cognitive skills, higher adaptive behavior scores at baseline may have better outcomes from early intensive applied behavior analysis-based interventions, but I would say they probably would have better outcomes from any type of intervention because they already have prerequisite skills. Younger children have better outcomes from early intensive ABA. Research has shown that the younger the child starts, the more that child's developmental trajectory can change such that they ultimately transition into school and no longer need support. Now, that's not the case for every child, but we do know that starting younger is associated with better outcomes. I don't like that. Maybe I should say bigger outcomes, because better is a subjective term. For very young children, they might respond well to more naturalistic behavioral interventions. In other words, interventions that are delivered via more play-based context. Well, I agree with that. I mean, most 2-year-olds aren't going to sit in a chair. They're too little. So of course, we're going to deliver intervention in a more naturalistic context. And there are some other things noted in the literature that we won't get into. But the take-home point here is that younger is better. We say that we would rather do a lot of intervention for a relatively short duration and get that kid into mainstream supports, into a more mainstream type of environment as quickly as possible, rather than do a little bit forever. So now I'm going to turn it over to Bob to talk a little bit about intensity and what we know about this whole idea of intensity of intervention.
Sorry, I moved my mouse off my microphone. So one of the big contentious points that comes up when you're talking to the NDIA, the NDIS about early intervention is how much intervention is needed and what types of intervention is needed. The research is pretty clear that the most effective early intervention for children with autism starts at sort of 15 to 25 hours, depending on the child, and sometimes needs a bit more. You'll hear people say that, you know, it means 40 hours, but 40 hours was used to establish that you could make a difference. And the big question from the initial research was how low can you bring it down, because the number of hours actually affects the cost, and the NDIS wants to minimize its cost. At least in the short term. They should be thinking more about the long-term cost, but in the short term, they don't want to do more hours than are really necessary. And the research is pretty clear that the minimum number of hours is somewhere in the 15 to 25 hour range for most autistic children. That's per week. And the thing is, what happens during those hours? Well, there's a whole range of therapy interventions. You'll hear a lot of talk about different types of interventions. There's people talk about discrete trial training. That comes up. A lot of the time is spent doing different things in discrete trial training. For example, you may hear about PECS. It's a discrete trial training method that helps children learn to communicate using the sort of conventional means, but it starts off with a very structured approach. We focus on creating teachable moments and using teachable moments. So quite often, a program will vary a little because a child does something new and interesting, and a really good therapist will pick up on that and use a teachable moment. Sometimes we have to work hard to create them. Sometimes the child actually gives you the opportunity to do it yourself. Basically, it's about teaching skills initially, and often in an environment where there's less distraction, and then you take it to a more generalized setting. So that the child learns to be able to apply skills in a whole range of settings. That used to be called generalization. There's a lot of talk these days about learning in natural settings. I'm not convinced that they're hugely different, but you know, this is the modern terminology that people use. We teach all sorts of skills. I mean, imitation was mentioned earlier. That's a sort of key skill. If you have a child that, when you say do this, doesn't imitate you, then they're going to struggle to learn in generalized settings. There's generally high rates of positive reinforcement to develop skills and to maintain skills. Yeah, those are most of the things.
I think one of the key areas of misinformation sometimes is that people think the 15 to 25 hours per week is just all tabletop, like academic instruction, like drill, 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 drill. And it just, kids hate it, and we have to drag them to the table, and it's really aversive, when that's not at all what it looks like. It's a mix of a whole bunch of different types of tactics. And a lot of it does occur within the context of play and routines and daily household activities, things that kids would do. It's just that instead of doing them sort of incidentally, they're done in a way that's structured. So we provide the right level of support, we create the teachable moments, we take data and make database decisions about how the child is progressing. So it really is a really dynamic, really enriched type of context where the child's needs are being met, their communication is facilitated, and people understand them. All right.
I think one of the other really important lessons is, I mean, things like play need to be taught to some of these children, because if they're going to play with other children and socialize and talk about play and imagination, I mean, imagination is a really important skill, and that's a really difficult thing to teach. But the other thing I'd say about the intensity is that you'll hear people say, that's, you know, how are children going to put up with 15, 20 hours, 25 hours of intervention? One of the really key things about intervention is it should be fun for the child.
Yeah.
In my experience, my son certainly wanted to be in therapy all of the time. You know, and most children love having the attention of an adult for so much of the time, especially when it's so positive. So one of the concerns that you'll hear is that children can't take that. My experience of this with quite a number of children has been that children actually like it and they will ask for it in most cases, especially if it's being done well.
Yeah.
The other issue is around what the role of parents is in early intervention. I haven't actually talked to Erin about this. One of my concerns is that the NDIS likes to say, well, we can just replace therapists with parents. The parents can do the 15, 25 hours. Well, that's not what was done in the research that the ABIA stuff is based on. The parents, as Erin suggested, had a significant say in what the program is about and how the family is going to work, what skills the child is going to learn and their priorities. And they supported the therapy when the therapists aren't there. So the rest of the life is about parenting, right? So parents have this involvement in saying, this is the world that the child is going to live in. So it's going to affect how the skills are taught, which particular skills get priority, that sort of stuff. And then they're going to be backing up the therapy work for the rest of the time for the child, if they're basically at home with the child. This slide is really quite nice, and it separates the roles of parenting and therapy. So you can see it says, you know, parenting is basically all day, every day, well, except for the time that they're in therapy or maybe in childcare. Parenting is often unstructured. It's the working in the natural environment anyway. It's possibly more about play, because children actually have to learn how to fill up their day. And if the only repertoire that a child has is either eating, having a bath, or lining up toy cars, then their day doesn't get very full. They actually need to learn a whole bunch of other play skills and other things that they're going to do. So there are all sorts of daily activities. All of that stuff becomes really important. Also, promotion of communication. I mean, remember that in many cases, parents have autistic traits themselves. That's how they get to have autistic children. And they may not be natural communicators themselves. So they may need a little bit of help and guidance about being more communicative with their child. That sort of stuff is really quite important. And the therapy is really the high intensity stuff, the teaching stuff that doesn't get taught by parents. But it also involves data collection, checking off that children are making milestones, achieving and progressing towards being able to function in a school, in being included in mainstream schools, making sure that those kind of directions are happening. So there are really quite significant differences. And the idea of replacing therapy with parents is not actually supported by the evidence very well. If you actually go through the literature and say, how much evidence is there that you can replace therapists with parents? Certainly my reading of the literature says that that really is not supported by the evidence, that parents do have a big role.
I think the other problem with this role that parents are the therapists, we're going to give you a key worker and then parents are just going to do all the therapy, is that it promotes inequality within the scheme. Because how many parents can set aside 15 to 25 hours a week and just dedicate one-to-one time with their child with autism when they have other children in the house, when they have to work full time, when they have a mental health condition that they're dealing with of their own? Is it fair to say that only families who have the luxury of having a parent who can dedicate that time can access best practice early intervention? I don't think so.
I think a single mum with 3 autistic children is going to struggle to provide 3 lots of 20 hours while looking after 2 other autistic children.
Totally. And that's the argument right there, is that it just promotes inequality.
Yep.
And I think, Erin, there is a comment there about the CRC report, and we are going to talk in a minute about the government funded reports and what they say and what you're likely to hear at the moment.
All right, well, we'll turn it over to Sharon and then we'll Shannon, and then we'll circle back and have a quick chat about the CRC report.
We've talked a bit about the essential practice components of early intervention, but I'll just go over them again and what that might mean for you and your family and your child, and what you're looking for when you're choosing an intervention. So the first step there, as Erin was saying before, is an assessment to identify the person's strengths. So this should be an individual assessment, not an assessment of autism diagnosis, but an assessment of your child and what that means for them. Understanding of behaviours, why they happen, what your child is using that behaviour to get or to get out of, and what that means. Different behaviour, I mean, the same behaviour can mean 2 different things for 2 different kids. So it really has to be very specific to your child. And emphasis on teaching the important skills. And this one often comes up as kids get older too. And Peter Gerhardt, who will speak at the conference, has some lovely information about how we sort of move from focusing on the sort of academics and those types of skills when kids are younger and moving into those adaptive skills. And I know we're always looking at least 5 years ahead. What is he or she going to need in 5 years' time, and what do we need to teach? That John McKechnie has this quote about the diet of an octopus, and walking into a classroom where kids weren't communicating fluently and needed a lot of help with their daily self-care, and they were working on the diet of an octopus. And it's like, we've got to decide what's important, because lots of these things take lots of time to teach. So we really need to be focused on what can we teach our kids that gives them the best opportunity to define their own future, and to make choices as they get older about what they want to do or not do. So it's important that those skills are prioritised, and that the providers you're working with are able to talk to you about why they're working on a skill and what that means for your child's life now and into the future. There should be some form of analysis and data. We should be tracking what we're doing, understanding why we're making decisions. Evidence-based intervention isn't willy-nilly. There are really good rationales, and it is based on hypothesis. So this is what we think is happening, this is what we're going to do, and this is how we're going to track whether this is working or not. So you should be able to say, this is how I know this is working for my child. And if you don't know that, then your provider, your therapist should be able to work with you to help you understand. I know it doesn't look like anything big has happened in this last week, but let me tell you about the small components and why we feel like this is the right strategy and why it's heading in the right direction. So it's really important that there's something objective to come back to. I talk to many parents in different places, and they say, well, I think it's working, I don't really know. For all the parents that we work with, we really want you to be able to say, I know why my child is working on what they're working on, and I know that it's working, and you feel like you're heading in the right direction. The other one there is training and support for you as a family, for everyone that is around your child, ideally. And that the people who are responsible for teaching your child or designing that program really have a lot of training experience themselves. I think as all autism interventions grow, and ABA included, that we really need to make sure that the people who are delivering those programs are highly skilled, that have both the formal education, but also the depth and breadth of experience for working with children with autism or adults with autism, if that's the group of people that they're working with. Thanks, Erin. So as we mentioned, there have been a number of reports over the years that look at the evidence that is available, which you would think then things should be more easily funded. Essentially, those reports have found exactly what Erin described earlier around what is evidence-based and what is not evidence-based, including the CRC report that has recently been released. And what happens with these things is they tend to, funding bodies and NDIA tend to pick very sort of single statements and overgeneralize those. One of the ones that Bob raised before was, one thing you'll hear at the moment, as we were saying, is that parents should do the intervention. And there is a quote in the CRC document, I think, that talks about how interventions that had parental involvement were more effective than those without it. But that doesn't mean that parental involvement was the only thing that was happening. That's on top of the intensive intervention that your child's getting from therapists as well. And like we talked about, we know that you're doing things with your kids all day, but don't let them get away with that, I guess. And we would always challenge that. And you'll hear it from planners, you'll hear it from NDIA staff that parents should be doing the intervention. And it's like we were saying, not founded in evidence, and not the expectation you should have of yourself. It's an unrealistic expectation that you should be able to do this. There are people who are trained how to do this, whose job it is to do this, and they do their job and then they go home, which is very different to parenting. So there's not much to say about that one, except that they are wrong, and that we shouldn't let them get away with saying that is truth when it really isn't. The other one that we'll hear, I think was listed in the comments, is that they're 15 to 25 hours, and they're saying that lower intensity intervention is as effective as higher intensity intervention. Also wrong. And there are studies that compare eclectic intervention with behavioural intervention. There are studies that compare low hours with higher hours, and they're wrong about that. That is one thing that the NDIA are onto at the moment. They used to say, you have to try other things before we'll fund ABA. And now they're saying you have to try low intensity ABA before we'll try high intensity ABA. Again, don't let them get away with that. It's not based in evidence, which is why we talk about in a minute the things that they are funding. And when they get to the appeals section of the NDIA Act and through the process, that those things do get funded because the evidence comes into play. So if you hear something and you think, how am I going to do this? The NDIA is saying, no, you just push on to the next step, because they are wrong, and there's not the evidence to support that.
And we're working on a rebuttal to that claim, or a clarification around that claim in the CRC report, that people are interpreting as intensity doesn't matter. That's not what the report even said. No. The report said they just can't conclusively determine X number of hours is perfect, because every kid is different. So it really, again, comes back to this idea of individualization, and that there probably is a minimum number of hours, which is ideal. And the research has consistently pointed to that 15 to 20 hours a week. So we're putting together some documents to sort of help people articulate that point when they come up against those, that pushback maybe from the NDIA moving forward, because we think that if it goes in front of an AAT, that our evidence is going to hold up.
And it really does. And I think it can be, for families who are planning and providers working with families who are planning, it can be really hard because there's just nothing you can do to change their mind. And I think about it as like, thank you, next, like move on. We're not going to change your mind. We actually don't need to change your mind. We're moving up and we're escalating things further. So I wouldn't put too much of a battle in trying to change your planner's mind. It's always worth trying to get them to want to help you. But as you get through the process, you will get what your kids need, because the evidence does support you wanting to do this. Sorry, I will talk very fast. So I think we've gone over most of the things to consider when selecting a therapy. And I know next week is about choosing a provider, but what's the focus of the therapy? Anything that's not focused on teaching, be skeptical about, as Erin has said there. What are the positive outcomes that your child or you yourself are going to get out of therapy? Is it based in evidence? And by evidence, really peer-reviewed research. Individuals can produce their own research, but that is different to research that other people have looked at and said the quality of that study is good enough. That they're qualified people who are providing the therapy, like I talked about before. I'm going to skip on to the next one, Erin. I think, again, there's some red flags that anything that claims to cure autism, I would be wary of. Anything that's a miracle cure or a quick fix, the research doesn't support that at the moment. It is lots and lots of teaching that gets us places right now. Children taking things, and yet there is a place for medication for certain kids who have other things that they need that for, but anything that you're taking at the moment, the research doesn't support. And like Erin was saying, therapy should be fun. This is not about forcing kids to do things. It's about motivating kids and being playful and imaginative and engaging. And your children really should be enjoying the process of learning. Anything that's not collecting data, even if it's an evidence-based program. So if you're doing behavioural intervention, but the data isn't there and the decisions aren't being informed by data, that means it's no longer evidence-based. So it doesn't mean that we need to take data points for every single thing that we're doing, but there should be something that is something objective that's guiding our decision-making. There's some references, and I think we are going to share the slides.
Yeah,
so.
Yeah, we can email out the slides to everybody who registered, and we'll also put them on our website. We're putting the recordings on our website, so we'll put the PowerPoint slideshow there, because some of these have clickable links, including, again, a link to the Raising Children Network parent guide for therapies for autism. This is a government website. On the website, they say in black and white, this is the evidence for interventions like ABA-based interventions, early intensive behavioral intervention. And they also show a lot of the things that are out there that have no evidence whatsoever. Again, this is a government website. This is the government's own words. So I highly recommend using that website as a resource.
Mm-hmm. And there are a number of cases that have gone to appeal, most cases where families have asked for a review of their NDIS plan. Almost all of them settle before a hearing. But there are some cases that have gone to hearing where the AAT has deemed intensive therapies and evidence-based practices as reasonable and necessary. So there are families who have, I guess, paved that way. Many more who have settled in mediation before hearing. So do know that you can be successful. We as providers and organisations like the ABIA really need to figure out how we can support you better to go through the process that you have to go through at the moment, because it is long. We shouldn't underestimate how stressful it can be, but you will get there. And if you come with a team to support you who are willing to provide evidence again and again and again, that there are many families who are accessing these services through NDIS funding.
All right, so we'll open it up. We'll just hang out for a few more minutes and see if anyone has any questions. Selena, that's fantastic. Yep, that's been all of our experiences as well, is that the majority of families that we've supported, they haven't even, AAT means that your case is going through the independent sort of court system with people who aren't the NDIS making a decision. Often what happens, even if you get to that point, settles in what's called mediation before it goes in front of a judge. So the links we just had up on the screen were ones that actually went all the way in front of a judge and had like a formal ruling. And in every single one of those cases, the judge ruled that the ABA-based program, the Early Intensive Behavioral Intervention Program, was reasonable and necessary, represented value for the money, and should be funded in full. But a lot of times you'll get to that point as a family in mediation before you get to that point. So just know that it's hard because so many families settle, it never goes on public record. So we don't have like this huge bank of data that we can show you, but just know that it's a really successful avenue for families to pursue if they're not happy with what they've received. And in our webinar numbers 5 and 6 in a couple of months or a couple of weeks, we'll be talking a little bit more in detail about how to navigate the internal reviews process and the appeals process. So for families who feel like they need to learn a little bit more about that to be able to sort of navigate it, we'll be having 2 webinars just on that topic coming up. Any other questions? Thank you all so much for coming. Hopefully this was helpful. We just have a quick poll for you. I'm going to pop it up on screen. If you don't mind taking a few minutes and just filling out answering the questions in the poll, we'd really appreciate it. By the way, can you see the poll for other people? Or just
I
yourself?
can see the questions.
I have no idea what this looks like. I need to know what it looks like from another person's perspective. But I'll just give you a minute to go ahead and fill out that poll. And if you have any follow-up questions that come to mind or that we weren't able to get to or anything at all, you can email info@abia.net.au, and Carol will be able to put you in touch with any one of us if you feel like you need some additional support. We really are trying to help empower parents to understand the NDIS and be able to go through the process and understand it and get a really good outcome for your family. So we want to be able to support you in that process. And we'll be continuing to create some new resources along with our parent packet. Our parent packet that you can download about the NDIS is sort of a step-by-step guide, but again, creating some new resources around what does the research say around intensity of intervention, what does an evidence-based program look like. We'll be continuing to provide some more resources around that. And we really hope you can all come to our conference later this year. It's going to be awesome. We have some great speakers. Daniela, I see you raised your hand and I have no idea how to call on you. So if you want to go ahead and put something in the chat window, go for it. Otherwise, looks like most people have responded to the poll, which is awesome. And okay, no worries. I'm like, I don't know how to call on people who raise their hand. But I think that's it for tonight. So we'll let y'all go now. Thank you all so much for coming. Have a wonderful evening, and we'll see you at the next one. Bye, guys.